Alrighty, everybody. We're going to get started. My name is Nicole Bashel. I'm a critical care and cardiothoracic anesthesiologist from the Cleveland Clinic. I'm here with my colleagues, Dr. Merrick Makov from the University of Kentucky, who is a cardiothoracic anesthesiologist there, and Dr. Lee, who is a critical care and cardiothoracic anesthesiologist at the University of Colorado. And together we're going to present the management and treatment options for preoperative, intraoperative, and postoperative pulmonary hypertension. We're going to do 15-minute sessions of each of those intervals and then a Q&A at the end for everybody. So if you could just save your questions till that point, that would be great. So that way we can kind of get through the presentations.
All right.
Okay, Dr. Murmako.
All righty. Thank you, Dr. Bashel. It's a pleasure to be here. Welcome to San Antonio. And here we go. Do you guys see my slides? Very good. So my topic for today is perioperative management of pulmonary hypertension, specifically for preoperative management. I'm also internist and board-certified internal medicine doctor. And so I think this is a very relevant topic to my career so far. So our agenda for today is to review the updated definition and classification of patients with pulmonary hypertension, overview the diagnosis and management, key aspects of preoperative optimization, outline the principles of intraoperative management as well as postoperative care. So we'll start with a patient. We have a 27-year-old female. She's scheduled to undergo elective laparoscopic cholecystectomy for symptomatic cholecystitis, and she comes to your pre-anesthesia clinic. Here are her vital signs. You notice that she's low baseline oxygen saturation in the room air, about 91%. She's mildly obese with a BMI of 32, and her physical exam is notable for a loud S2 sound on the left upper sternal border, as well as bilateral lower extremity peding edema. Upon further questioning, she reports to you that her dyspnea got progressively worse over a few months. She can only walk now 1 block and has to stop to catch her breath. She doesn't smoke tobacco or use any tobacco products. She denies excessive alcohol, doesn't use any recreational drugs, and doesn't take any prescribed medications. So the question comes to mind: what is your initial workup, and what are your concerns for this patient? So you start with some basics. You obtain a complete blood count and comprehensive metabolic panel, which are generally unremarkable. However, her pro-BNP came back quite elevated. You also obtain 12 EKG, and you see that she has a right bundle branch block pattern in her right precordial leads, namely V1 to V3. And on the chest X-ray, you see that your right hilum is quite prominent, suggestive of a possible pulmonary hypertension. So next, you go with a transthoracic echo, and here you see apical four-chamber view. It's a little bit foreshortened, but you can notice that your RV is quite dilated and severely dysfunctional. You see some anechoic fluid near the right ventricular apex, suggestive of pericardial effusion. Next, you obtain a peristernal short axis view, and on the top of this view, you see the right ventricle, which is indeed quite dilated. Next is your interventricular septum and left ventricle on the bottom. You see that at the end of the systole, the interventricular septum is pushed towards the right side, which is indicative of severely elevated right-sided pulmonary pressures. And here you confirm this with an M mode. You see that the interventricular septum is indeed pushed towards the left heart during that systole. Here's your official echo review. She does have indeed reduced RV systolic function. She has estimated pulmonary arterial systolic pressure of 56 millimeters of mercury, normal LV function, normal LV valves, and moderate pericardial effusion without evidence of tamponade. Then you refer this patient to cardiology colleagues who perform right-sided heart catheterization. And you notice that she has quite elevated pulmonary vascular resistance of almost 9 Woods units. And she has reduced mixed venous saturation of 58%, and she has reduced cardiac index of 1.9. Next, she undergoes functional assessment. She's able to walk only 390 meters for a 6-minute walk test. Her peak oxygen consumption with CPAT test is only 13 milliliters per kilogram per minute, and she has reduced the LCO or diffusion capacity for carbon dioxide of only 55%. So here's some of the questions which we'll try and answer during this presentation. So what's the patient's diagnosis? Our patient has type 1 pulmonary arterial hypertension, and we'll go through that. So in order for us to understand pulmonary hypertension, it is important to note that it's a heterogeneous group of disorders. Current updated definition for diagnosis tells us that the mean pulmonary arterial pressure of at least 20 is needed. And unfortunately, pulmonary hypertension by itself is independently associated with worse peripheral outcomes. And if you look at this graph, you see that over time, the prevalence of patients undergoing non-cardiac surgery who have pulmonary hypertension is increasing. And I think this, unfortunately, will continue to rise because of the aging population and longer life expectancy. Here's how we subdivide patients into different groups from group 1, or PAH, pulmonary arterial hypertension, usually due to idiopathic or hereditary or drug and toxin associated. Group 2 is typically associated with left-sided cardiac disease. Group 3 is related to, Group 3 is related to hypoxemia or pulmonary disorders. Group 4 is typically due to pulmonary arterial obstruction. And Group 5 is usually due to miscellaneous causes. Pulmonary hypertension can also be classified into different groups based on the hemodynamic profile, what the cardiologist obtains during the right heart catheterization. So there are 3 main groups: precapillary, postcapillary, and mixed. Precapillary are typically groups 1, 3, 4, and 5, and postcapillary is typically group 2. So the distinguishing feature between the two is the wedge pressure and the PVR, pulmonary vascular resistance. The pathogenesis of pulmonary hypertension is quite complex. There are multiple genetical factors which play a role, also quite significant as an environmental factor. But overall, it leads to endothelial dysfunction, inside of thrombosis, pulmonary vascular remodeling, and RV pressure overload. In order for us to understand how the RV becomes dysfunctional pulmonary arterial hypertension, it is very essential for us to understand the normal physiology of the right ventricle. It was designed to operate with low pressure circulation. Thus, it has a much less muscle mass, and because of that, it doesn't usually do well when you rise PVR or pulmonary afterload significantly. It has quite complex shape, which complicates its assessment with echocardiography, and compared to its left-sided counterpart, it is perfused during both systole and diastole. Patterns of RV contraction are also important to understand. The most important one is believed to be longitudinal shortening from the tricuspid annulus towards the apex. Some other patterns of contraction which are also important include radial shortening, peristaltic contraction. Of note, it is important to remember that left ventricle also contributes to the RV ejection via interventricular septum. So over time, because of the elevated pulmonary afterload for the right ventricle, it leads to right ventricular hypertrophy, septal shift towards left, decreased RV output, worsening tricuspid regurgitation, low cardiac output, and eventually, unfortunately, death. Clinical presentation of patients with pulmonary arterial hypertension is unfortunately not very specific. These symptoms such as shortness of breath, fatigue, body edema, and ascites can be caused by multiple different pathologies. That's why clinical suspicion is essential. Clinical severity of pulmonary hypertension is based on the WHO classification system, and this classification system we'll come back to because it's quite important for us to understand what therapies these patients need to be placed on. In terms of the initial workup, it is important to go through this patterns of excluding concomitant diseases which can be treatable, such as, for example, sleep apnea, but by no means this is a comprehensive list. Basically, we want to look for any other diseases which can be modified, which can also contribute to the pathogenesis of pulmonary hypertension in a particular patient. In terms of the lab testing, unfortunately, there is no specific test which can diagnose your pulmonary hypertension. ProBNP can be elevated, but by no means it's a specific test. It can be abnormal with so many different pathologies. Echocardiography is very essential. By no means it's a diagnostic test. It's a screening test. What you want to do is screen and assess the RV size and function, presence of TR. If there's a TR present, it can help you estimate pulmonary arterial systolic pressure. And you want to also look for additional pathologies such as left-sided valve disease or left-sided cardiac disease or pericardial effusion. Echocardiography can also help you understand which patient is likely to have the pulmonary hypertension versus the one who probably doesn't have, based on the estimated PASP. I don't know why this is doing this. Based on the estimated PASP and TR velocity. For example, if TR velocity is more than 3.4 meters per second or PSP is more than 50, this is more likely to have pulmonary hypertension. Right heart catheterization is essential for diagnosis. It can also help you understand what type of pulmonary hypertension the patient has. You can also directly measure important variables such as, for example, cardiac output index, mean pulmonary arterial pressure mix, the venous saturation. And in select group of patients, you can also perform vasoreactivity tests and see if they are responders to calcium channel blockers. In terms of the prognosis and prognostication, REVEAL 2 score is quite important. However, this score has not been specifically devised to assess the risk for preoperative purposes. However, it can also help you understand which patients are at high risk. So some factors are protective, for example, PVR less than 5, but some factors are associated with negative outcomes, such as, for example, WHO class 4. In terms of the core concepts of outpatient management of these patients, group 1 patients usually are started on pH-targeted therapy, and we'll go through the medications. Group 2, 3, and 5, you manage the underlying disease. Group 4, these patients are managed typically with chronic anticoagulation, riociguat, pulmonary and thrombectomy for surgical candidates, and for patients who are not surgical candidates or who have distal disease, percutaneous balloon angioplasty can be considered. Supportive care is essential for them all, such as supplemental oxygen if the patient is hypoxemic, diuresis, and vaccination, and obviously lung transplantation is an option for appropriate patients. In terms of the pharmacotherapy, there are multiple classes of medications which are available. For example, working horses of the pH management include phosphodiesterase 5 inhibitors, such as sildenafil and tadalafil. It is important to remember that if the patient takes these medications, you have to be very careful with giving them nitroglycerin because it can lead to very profound hypertension. Another medication is riociguat, which was initially approved for type 4 or CTAF. We also have endothelin receptor antagonists, which should be avoided in patients who are trying to conceive. And we also have prostanoid and prostacyclin therapies, which can be given either orally, subcutaneously, inhalationally, or IV. I also want to briefly mention a new agent called sotatercept. It's a sub-Q medication given every 21 weeks. Every 21 days. It has a new mechanism of action. It has been shown to reduce mortality and transplantation-free survival in patients who have severe or class 4 pulmonary hypertension. It has certain side effects, which are listed here, namely thrombocytopenia and bleeding. So tiered pH therapy, again, like we discussed earlier, it's based on the functional classification. So when you have type 4 or WHO type 4, this patient should be started on combination oral therapy, parenteral prostanoid, and also sotatercept. So going back to our patient, she was diagnosed with group 1 pulmonary arterial hypertension class 2. She was prescribed low sodium diet. She was started on tadalafil, ambrisentan, and furosemide. She had a negative sleep study for sleep apnea. She was referred to cardiopulmonary rehab. And the next question comes to mind: when is it safe for her to undergo elective surgery? Just to remind ourselves, this is how we started, and we decided to see her 2 months from the initial visit in the pre-anesthesia clinic. And you notice that overall she improved quite a bit. Her weight decreased. Her proBNP is much better. She's more functional now. She's able to walk 470 meters. And her peak oxygen consumption also increased, as well as her echo parameters got better, and her right heart catheterization showed a normal cardiac output and normal mixed venous saturation. So here are the instructions you provide her before her surgery is to monitor her weight, continue low sodium diet, continue her pH medications, and skip the morning dose of furosemide. So in summary, the etiology of pulmonary hypertension is quite complex. Patients who have severe pulmonary hypertension, unfortunately, at very high risk of preoperative complications. This patient should be managed by a multidisciplinary team, and unless contraindicated, the vast majority of the times, this patient should continue the pH medications. Thank you. This is my email. If you guys have any questions later on, and like Dr. Bashel said, we'll leave the questions till the end.
I'm going to transition to the intraoperative management of pulmonary hypertension. The first thing we're going to go over, like with any case, is we're going to talk about your anesthetic of choice, right? So it's the first thing you do to decide how you're going to put this type of patient to sleep. They're obviously high risk at this point, so if you can avoid things like general endotracheal anesthesia, if they have a peripheral limb injury and you can do neuraxial or regional anesthesia, that would probably be the most ideal to maintain spontaneous ventilation, minimize hypercarbia, large swings, and induction. But in our case, unfortunately, because they're doing a laparoscopic cholecystectomy, it's going to be unlikely to be able to appropriately block them for the duration of the case without causing severe discomfort, in addition to the fact that they will have insufflation and hypercarbia with that as well. So then you come to the decision of, do you do general anesthesia with an endotracheal tube or you do it with an LMA? I think at this point most people would tend to agree that you should put the endotracheal tube in and not let them spontaneously breathe with an LMA, given that it is unlikely that you're going to be able to ventilate them appropriately, and you're going to have large swings in your hypoxic pulmonary vasoconstriction and suppression in your SVR. So here's the case. I'm just kind of going over originally the data that you were given prior. So these are her vital signs when she shows up day of surgery: reasonable blood pressures, heart rate. Her SpO2 on room air is 95%, much better than where she started at 91. She has significantly improved her bilateral lower extremity edema. Her walk test has improved. Her echo reports just a mildly dilated RV. Her TAPSE has gone up, and just a little bit of TR. Her updated right heart cath shows that her PVR is reduced significantly from 8 to 3. These are all good signs. She's basically been optimized from a preoperative setting, and it's much more encouraging when you go in to do a procedure, seeing that a patient has responded to outpatient therapies. And now you can also see here that her cardiac index has increased as well to 2.7, meaning that there was room to augment. So when you talk about putting these types of patients to sleep, so you want to go through basically what I think of as your core principles, right? So you're obviously going to do your monitoring. How are you going to monitor this patient? What are your choices? You do your standard ASA monitors like always. You know, they're high risk of having fatal arrhythmias, severe hypotension, RV dysfunction on induction, so pre-induction arterial line for pretty much anybody that has moderate to severe pulmonary hypertension like she does. And then you basically go with the question of, do you add in a pulmonary arterial catheter and do you add in a TEE or not? So the pulmonary arterial catheter in this case would probably be the most useful thing to add. It gives you numbers, it's easy to place. And then outside of that, if for any reason something happens intraoperatively or postoperatively, they have it throughout that duration as well. TEE, you can save for later if you need it. In this case, it's a laparoscopic cholecystectomy, so they need decompression in the stomach. And then if you needed to, you can add it later. But for now, given that she has had improvement, we'll start with the pulmonary arterial catheter. The considerations that you want to have for this is her cardiac status, so how functional she is, how much oxygen support is she on, is she in sinus rhythm, making sure that you maintain a good acid-base status, so normal pHs, normal CO2s on your blood gases. And then the other thing to consider in all of this is the type of surgery. Is it emergent? Do they have high risk of decompensation during the case? These are all things you want to keep in mind. All right, so the next thing is that you have to get this plane off the ground, right? So you have to induce them. We talked about the pre-induction arterial line. You want good IV access that you trust. Whether or not you do the central line awake or asleep would be up to you when you see these patients. Do they look compensated? Have they responded to outpatient therapies? Is this an emergent procedure? Will they tolerate laying under a drape for 15 minutes, being anxious? Having someone stick their neck. All those things are going to go into whether or not you place this line in their neck before induction or post-induction. She's coming in from outpatient for an elective procedure. She's been optimized by cardiology. It's something that you can do post-induction, but in this case, you definitely want to make sure that you have good IV access. She has what we would think of as like a physiologically difficult airway. She's very tenuous. You cannot give her the amount of time that it's required to hypoventilate her during induction when you bag mask her. So getting to sleep, getting stabilized, getting the breathing tube in is an important aspect of this. And throughout all of this, you want to maintain your MAP greater than 65 at least for your RV perfusion. It's less about the LV in this case and more about the right ventricle, because you want to make sure that it maintains it, because the RV is much more sensitive to ischemic events. And so you want to make sure that you maintain it. And then post-induction, you can insert the central line, you can insert your pulmonary artery catheter, and during the start, you can see what your baseline is before you ever alter anything else physiologically. So in this case, because we're doing an intra-abdominal procedure with insufflation, you can see where her baseline is for you prior to any other perturbations, and hold off on the echo for now. So this is the kind of the updated flow guideline from the International Pulmonary Hypertension Management, and basically it goes through kind of how you decide on your monitoring, the things that you have to treat pre and post in terms of complications, things to avoid. It does say at this point to optimize their preload to CVPs of 5 to 10s. I think this is a very flexible number because sometimes these patients, they live at a higher CVP because that's what it requires to fill their RV. But you want to make sure that it's close to their baseline and that they've been optimized throughout. But these are sort of your core principles for intraoperative anesthesia: maintaining your MAPs, maintaining your systolic blood pressures, making sure that your cardiac indices are high or normal, and making sure that they're above 2 so that you have good output. You want to make sure your wedge is appropriate. So this here is your wedge, and essentially it says less than 18. So essentially you don't want them to be in left-sided heart failure, because if you go into left-sided heart failure, it makes it more likely that you go into right. When you change the intrathoracic pressures during induction, you want to maintain their mean pulmonary pressures less than 35. So, when they come in, they're already elevated above 20, but you don't want them to go super systemic, because in that point you have no forward flow or perfusion. So you have to maintain them below around a mean of 35. Okay. The general risk factors that you tend to run into just post-induction, or you can go into arrhythmias. Sinus rhythm is always the goal because you need the filling from the atrium into the ventricle. If typically these patients are on outpatient calcium channel blockers or low-dose beta blockers, you want to continue them throughout because you don't want to induce arrhythmias. And then you obviously want to avoid systemic hypotension for reasons we talked about. Your ventilation strategies, you want to avoid high airway pressures, because then it becomes increased afterload for the RV, and in a struggling RV, it will not tolerate it, and it will propagate essentially complete failure. So you want to make sure that your PEEP is appropriate for ventilation, but that you're not over-insufflating them. You want to keep good tidal volumes, the normal things that we're taught, 6 to 8 mLs per kg. You want to maintain their PA CO2s between 30 and 35. But this is why you have your A-line, so that you can compare your gradients and make sure that your PA CO2s are maintaining low. And then maintain their SpO2s higher than 92. The other thing that you can get into with these patients is the coagulation. So as my colleague had said, they can be on agents that make them thrombocytopenic, so you can get into bleeding issues, you can get into coagulation difficulties, even for simple procedures. So it's just something to keep in mind of if they start to have bleeding from something that you would otherwise think is not a problem, from like an ankle or a reasonable knee, or in this case like a lap chole, barring there's any large vessel bleeding, they can be prone to coagulation type bleeding as well. So we're going to talk now specifically about right ventricular risk factors and concerns. So one thing you have to be mindful of is the loading conditions to which your RV has. So as I said earlier, like CVP is a fluid number, and you need to watch the trends rather than maintaining just a set range of 5 to 10, because sometimes these patients live at a higher filling pressure. So you need to make sure before you go to sleep that you feel like they're not hypovolemic, that you're not going to have issues with like reduced mean arterial pressures or RV perfusion, because if they don't have enough filling, then there won't be enough ejection. You also obviously don't want the other end of things where you have hypervolemia, which is very poorly tolerated, especially in patients that have long-standing pulmonary hypertension and have developed RV hypertrophy, because then at this point you start to develop essentially a filling pressure defect on the right side, and you have increased wall tension when those patients get overloaded with volume. So things that are helpful in all of this are obviously diuretics, changes in position. Head up is always the best for the RV because it offloads it, which in our situation will be the case for positioning. You want to augment the contractility, so enhancing the contractility of the right ventricle with ionotropes, milrinone, dobutamine, epi, all those things to enhance contractility, but also making sure that you have pulmonary vasodilation as well, and offloading the back end of the right ventricle. And then last but not least, you want to make sure that they're not cold, because it propagates things such as arrhythmias, acidemia, coagulation issues, and then starts down sort of the pathway that would lead to complete RV failure in this case. And unlike the left ventricle, if the RV starts to fail, it is less forgiving, and it is hard to get it to come back and start to contract appropriately. So we try to prevent rather than play catch up. The next thing we want to consider always is the surgical considerations. What are they doing? How long are they going to do it? What are the physiological effects of the procedure itself? They're stratified across different groups. You have low-risk procedures, which are listed here, intermediate, and high. Anything that's emergent is always a high-risk procedure, so we try to make sure we can schedule and do elective things so that we can optimize them outpatient, or if not, even give them a couple days preoperatively, even if it's on the floor in the ICU, before taking them if you can. In reference to our specific case, you have a laparoscopic procedure, which has multiple concerns, right? So you are concerned about insufflation, which causes increased peak airway pressures, alterations in RV preload and afterload. Many times people increase the PEEP to allow for better ventilation, which increases the intrathoracic pressures. You can get mechanical compression. All these things cause increases in your pulmonary vascular resistance, and it makes it harder for your RV to contract against. And then on top of that, when you change the positioning, right? So this patient ends up being in reverse T, so then there's venous pooling. So then you have volume, but it's not in the right ventricle. So are you filled enough? And then you have the issues with insufflation, such as bradycardia. So there's less sympathetic tone, less contractility. And then will you induce arrhythmias as well with that? So when you think about a laparoscopic procedure in an elective patient, the goal initially is obviously to stay laparoscopic. However, the recommendation now is that if you think you're going to get into a prolonged difficulties, you're going to have a procedure lasting more than 3 hours, that the discussion is had to actually just open, because then you do not have as many perturbations in physiology associated with the insufflation and the procedure itself. So intraoperatively, we end up with these developments. So at this point, they've been insufflated, they've had prolonged surgical time, they don't want to open because they do not want to have issues postoperatively with pain, breathing, any of those things. So they decide to stay laparoscopic. The patient's not tolerating this. She's developing acidosis. Her PCO2 is climbing because she's unable to ventilate properly. Her pulmonary artery pressures are going up. We initially started, in the 50s and 30s, and now we're in the 70s and 50s with her mean going up. And here you can see this on this side here. This is the right ventricle slowly pushing over, compressing the LV here. And essentially, this is a sign of impending RV failure.
Oh yeah, look, it's bad.
So the concern here is that you're not going to be able to support. So you increase your ventilation, you add epinephrine, you add milrinone, you add things you can do to increase contractility and anomotropy and offload the RV by decreasing your pulmonary vascular resistance. However, your ABGs are getting worse, your PCO2s are getting worse, your PaO2s are getting worse, all things that propagate that you're going to have RV failure. And these are other options that you can add in if your basic drugs don't work. You can inhale nitric oxide. You can add inhaled prostaglandins, inhaled milrinone. The trick with milrinone is to make sure you atomize it appropriately. The recommendation right now is about 5 milligrams inhaled to try and offload the RV as best you can. And this is the recommendation for groups 1 and 4, and it's broken down here based on the groups that they fall into. If they're already on PO or IV sildenafil or tadalafil, you continue that. You add the contractility. If you think they've been volume overloaded, you diurese them. So due to all these complications, all the things that you have done to try and augment them, unfortunately, she has not tolerated this, and you decide to send her to the ICU because she needs further optimization to require extubation at this point. So the TE was showing moderate to severe dysfunction, your TAPSE has dropped, and your TR is now 3+. So now you have to send her to the ICU for further management so that she can be optimized appropriately before she can be extubated.
All right, now we will move on to our patient's post-operative care. So pulmonary arterial hypertension is a group that continues to challenge us, even with the advances in our anesthetics and critical care. So those patients face a 2 to 4-fold of higher rates of major complications after non-cardiac surgery. So the first 48 to 72 hours post-op are the danger zone when the RV is most vulnerable and small triggers can snowball into catastrophic complications. We will continue with our case. So after all that has happened intra-op, our patient arrived to the ICU, intubated and sedated on dexmedetomidine. She's stable currently for sign-out. However, midway through the handoff, she coughed on the ventilator, and within seconds, her heart rate shot up to 130 sinus rhythm, and her blood pressure dropped to 70/40s with a raised PA pressure to 50/30. At around the same time, her oxygen saturation fell into the mid-80s on 50% FiO2. So that's all it takes, a cough, a bug, or just a few seconds of hypoxia. For someone with this severe pulmonary hypertension, it can just push the RV into total failure. So that's why the transitioning from the operating room to the ICU is just as important as our intraoperative management. So when we think about that transition, I'm not just listening to the anesthetic summary. I'm also thinking about risk stratification for this patient in the ICU. So I want to know what were the patient's filling pressures on the pre-op right heart cath? Where did we start with? And what was the patient's baseline functional status? What chronic therapies are they on? And when was the last time they took their medications to make sure they're on their schedule? And I also want to know what the intra-op course was like. But above all, how is the RV doing on the intra-op TEE that we did just now? Because our success in the ICU depends almost entirely on how the right ventricle tolerates the first few hours of recovery. And we also focus on systemic perfusion, volume status, and the events during transport. So in the ICU, our monitoring has to be intentional. An arterial line is a given. And a central line with a PA catheter is necessary when the patient is on vasoactives or pulmonary vasodilators for us to trend the patient's filling pressure and trend the cardiac index. I also rely heavily on bedside echo. I'm watching the size of the RV, the function of the RV, the septal motion, and I use point-of-care ultrasound to assess volume status. I keep those patients on continuous telemetry to monitor for arrhythmia. And I'm also checking ABGs to avoid hypoxia, hypercapnia, acidosis, all of which will drive up your pulmonary vascular resistance. I'm also tracking urine output, lactate as perfusion markers. And temperature monitoring is extremely important because even mild hypothermia can cause pulmonary vasoconstriction. So it's small details like these that keep the RV perfused and the patient stable. So the common pitfalls in the first few hours are pretty predictable. They include hemodynamic instability, hypoxia or hypercapnia, inadequate pain control, and interruptions in their home PAH therapy. So each of those will raise your pulmonary vascular resistance, and once that happens, your right ventricular output will drop, and then you will have lower left-sided filling pressures, and then you're on the path toward cardiogenic shock. So the best way to treat it is never to let it happen. Sedation of those patients who remain intubated at the end of the case is one of the most overlooked aspects of your post-operative management. So over-sedation leads to hypoventilation and CO2 retention on their spontaneous breathing trial. However, under-sedation will lead to coughing and agitation. Both of these will increase your pulmonary pressures. So I keep their sedation light but steady, and I make sure they have effective analgesia on board. Whenever I can use regional techniques for analgesia, I try my best to get their pain control with regional techniques. And for ventilation, we avoid hypoxia, hypercapnia, and acidosis. I use lung protective settings with low to moderate PEEP. And when the patient is ready, I extubate early but deliberately once they're off their inhaled pulmonary vasodilators. So their emergence needs to be smooth, a calm, steady extubation rather than a fight with the vent. That's how you prevent those sudden right ventricular pressure spikes. And supporting the RV is the cornerstone of what we do. So I try to maintain sinus rhythm because development of supraventricular tachycardia is an independent risk factor for death in patients with PH. And when contractility falls, I reach for inotropes like dobutamine or Mironil, and I pair them with vasopressors such as norepinephrine or vasopressin to maintain their systemic perfusion. And when your pulmonary pressures start to climb, inhaled vasodilators like nitric oxide or epoprostenol can make all the difference. And multiple studies have shown that those two agents are equivalent for short-term RV afterload reduction when used carefully in the ICU. However, the nitric oxide is significantly more expensive than epoprostenol. When despite all of these interventions, if the RV continues to fail, it's time to escalate. So mechanical support with VA ECMO can stabilize the patient by offloading both the RV and their pulmonary circulation. RVAS, on the other hand, have a very limited role in severe pre-capillary PH case because they just cannot overcome the fixed afterload in the pulmonary circulation. And they will not improve your RV pressure overload and may actually, paradoxically, induce more RV dysfunction by increasing your risk of lung injury, pulmonary hemorrhage, hypovolemic shock from hemorrhage, and low cardiac output. So unless their pulmonary pressure is controlled, I do not consult cardiac surgeons for RVAS in those patients. And then one thing we cannot afford to forget is the continuity of their chronic pulmonary hypertension therapy, because interrupting those therapies can undo months of stability in a single day. So even while we focus on hemodynamics and ventilation, we need to make sure those home therapies are resumed as soon as possible. So to start, sotatercept can be continued as a sub-Q injection. And your prostaglandins have IV and inhalational forms that could be continued. Moving on to sildenafil is available for IV administration. Unfortunately, most of your endothelin receptor antagonists cannot be crushed and delivered through an NG tube. However, a liquid suspension of bosentan is available. So we, when those patients get to the ICU, we would get a nasogastric tube as soon as possible to continue their home therapy if needed. So to bring all of it together, transition from the OR to the ICU carefully because it sets the tone for everything that follows. We prevent triggers that will increase your pulmonary vascular resistance. We keep sedation and extubation smooth and controlled. And we support the RV with preload optimization, plus minus diuretics if the patient's overloaded after their intra-op course. We use inotropes to support the RV contractility when the RV starts to fail. And we use vasopressors to maintain the RV perfusion. And then we use inhaled vasodilators for RV afterload reduction. And if the RV continues to fail, we escalate early. We consult our cardiac surgeons, and we start them on VA ECMO. And every step we take in the ICU is aimed at protecting the right ventricle, maintaining your RV pulmonary arterial coupling, and buying the patient more time to recover. And these are my references. Thank you.
Hi, I'm Ramu from University of Colorado. So we were actually just talking about this in pre-op clinic the other day. Are there any thresholds where you talk to the surgeon and say, even beforehand, hey, we think you should open or start open, or do you always say, hey, let's see how the patient responds, put them under anesthesia, obviously do your monitoring, et cetera? What thresholds do you have for that?
I'll let IBAC answer the pre-op.
Okay, do you want to?
Yeah, thank you for wonderful question. So I think it depends how the patient did with optimization. First of all, looks like our patient improved significantly in our particular case, and there are definitely some benefits of laparoscopic approach. Shorter recovery, less pain, more cosmetically appealing to the patient. So I think in this particular patient, it was reasonable to start laparoscopically. Let's say if this patient didn't improve that much, I would have a much lower threshold of talking to the surgeon and telling him or her that maybe in this particular case, in order to avoid this excessive CO2 absorption and positioning and potential longer surgery, longer mechanical ventilation, I would have a lower threshold to advocate for an open approach if she didn't improve as well.
And similarly, are there any thresholds where you start inhaled or IV vasodilating agents on the front end, even before?
I would think that when you go to induce and you see what your pulmonary pressures are comparatively to what they were on the right heart cath pre-induction when they were an outpatient in clinic, and see what differences you have. If you have any significant uptrends in your mean pulmonary pressures, and you're having trouble with your perfusion, so you're having trouble maintaining your mean arterial perfusions, any concerns that your right heart is essentially failing, as I would start it then.
Okay, thanks.
And I think it also depends on what your institutional guideline is. For example, at University of Colorado, we are not able to start inhaled pulmonary vasodilators when the patient is not intubated. But at Cleveland Clinic, they can run inhaled epoprostenol through heated high flow nasal cannula. So depending on your institution, you might have the choice to do it or not.
Hi, John Click from UVM. Can you just elaborate a little more on why you guys go straight to ECMO versus isolated RV support in the setting of somebody who's medically failing pulmonary hypertension? Because in my institution, we would typically go to an RP Flex or an Impella RP instead of going straight to ECMO.
Yeah, so it was mentioned on the most recent circulation guideline for perioperative management for PH. The article was published in 2023. There are several studies that have shown that in patients with uncontrolled PH and high pulmonary pressures, RVAD actually increased their mortality. So we usually don't start RVAD until we have some control of their pulmonary pressures.
Is there evidence that ECMO actually improves their mortality, or is it just a sign of the underlying disease process? Is my question.
Yeah, it could be. But yeah, there's no evidence of VA ECMO actually decrease mortality.
Hello, my name is Amr. I'm one of the anesthesia consultant. Thanks for the interesting presentation. Just a couple of questions. Firstly, how you grade the severity of the pulmonary hypertension? Is that only based on the pulmonary artery pressure, or is there any other objective factors you look at? That's my first question. My second question is that we don't usually stock the pulmonary vasodilators in theater. So would you advise, if I got a patient with a pulmonary hypertension, should we start stocking them in theater just in case things get to worst?
I think the first question is
Sure.
towards you.
Yeah, thank you. Thank you for your question. In terms of the severity of pulmonary arterial hypertension, obviously all of these patients should meet the definition based on the mean pressure, but also WHO classification based on the clinical symptoms and functional status is essential for you to certify the management of these patients. Another things, obviously, to look for can be RV function. How is RV dealing with this? Is it compensated or not? But the two main factors are mean pressure and mean pulmonary pressure and the functional status of the patient.
And then in terms of whether you stock it like chronic, like for everybody or just for this patient, so
For patient with pulmonary, if I'm scheduled to have a patient with pulmonary hypertension, would you advise to get these drugs stocked in theater just in case we need them?
yeah, I think if you see a patient that has high mean pulmonary pressures outpatient, low cardiac indices on their right heart cath outpatient, high pulmonary vascular resistance, so anything technically over 2 to 3 on their right heart cath, I would have something available to you so that you would have it for that case, yes.
Okay, thank you.
Thanks for the talk. Quick question on the milrinone, inhaled milrinone. What's the kind of the logistics of doing that? Do we use the same setup as we do with the Flolan? You said 5 milligrams. Is that over how long do you typically run that?
So I typically grab, it's the same setup for Flolan or for albuterol. You just need the nebulized atomizer that's heated that goes into the circuit. So some institutions have it where you can put it in the anesthesia circuit. Ours goes through an ICU ventilator. You just hook it into the inspiratory limb and then put 5 milligrams of milrinone in it, and then it heats and atomizes it like it does for all the other drugs, and then heat delivers it to the patient.
Okay.
And
then
it's usually given over about 15 minutes.
15. Okay, thanks.
If I may have a question for my colleagues here. So these patients are obviously very challenging to manage in the ICU, and you want to kind of reduce the amount of time they spend on mechanical ventilation, but at the same time, there's this concern that, when you lighten the sedation, they start coughing and there are some intrathoracic pressure swings. What's your experience or opinion on using ultra-short-acting opioids such as remifentanil to smoothen the emergence process and extubation? Thank you.
So from an ICU perspective, we don't typically use remifentanil for extubation. If we need to, we'll give them prolonged slow infusions of either fentanyl with Precedex or some low-dose propofol. That's the combination. We typically don't use remifentanil.
Yeah, I have similar experience. We usually don't start remifentanil in the ICU, and also you worry about if you don't have regional blocks on board, you might have hyperalgesia afterwards, so you might have more problem later.
I think it has more utility intraoperatively for extubation at the end than it would from an ICU perspective.
And what do you routinely what would you extubate this patient to? Jess?
Yeah, depending on how they are doing on their spontaneous breathing trial, if I have any concern about their oxygenation, I might consider heated high flow nasal cannula. And if they have sleep apnea and their baseline using BiPAP or CPAP at night, I would extubate directly to those positive pressure ventilation.
I have a quick question. I'm from Houston. Would it be a valid idea if his right side pressure is super higher than the left side? Temporarily, you create a shunt from right to left. Would it be acutely relieve the symptoms before any other advanced measurement can be done?
So in those situations, you want to get control of the elevated right-sided pressure, so you do what you need to do. So most of the time, you would add some type of inhaled vasodilator agent to offload the RV and add on some type of ionotropic agent. If you think it's a pure right-sided issue, you can try to do a bolus of milrinone with some vasopressin, because you want to drive your left-sided pressures up as best you can, because at that time you're also, in addition to having high RV filling pressures, you're having increased wall tension on the right side. You're also having no perfusion because the left side's not perfusing it as well. So you're starting, as I said, this kind of spiral of death of the right side. So you want to give something to have the left-sided pressures go up, whether it's vasopressin or Levophed, get the left-sided filling pressures up, give an ionotrope to get your RV to squeeze to push forward, and get something to offload the pulmonary vascular resistance. So milrinone, epi, something to get it to squeeze, and then as soon as you can, get something inhaled in to offload it as well that way without creating a systemic vasodilation as well.
Also, I want to make one comment about the intravenous prostacyclin these patients are on. Typically, they have some sort of indwelling catheter for that, typically like a Pickline or Hickman catheter. It is essential to remember that the half-life of this prostacyclin is very short. So you want to make sure that the supply you have of this medication is enough for your case, because it doesn't take much time for the medication's effect to wear off completely, and then it can precipitate pulmonary hypertension crisis. And like my colleagues mentioned, it can be sometimes impossible to resuscitate this patient from it. So make sure you have enough of this medicine in the operating room.
So
One last question. I know the Canadians have written about using intratracheal milrinone as a 5 milligram squirt down the endotracheal tube for salvage. Do you guys have any experience with that?
So we don't put it straight down the endotracheal tube because the absorption of that, the concentration that you would need to have would be high to get appropriate perfusion. So that's why we atomize it, so that there's better absorption into the tissues and it's aerosolized at that point. So that tends to work better than just putting straight volume down the tube. And then also you don't run into an issue of causing bronchospasm by putting large volume aliquots down into the respiratory system. So that way, at least it's more favorable for absorption to atomize it and heat it up. All right, well,
I guess just a follow-up on this question. So, would you stop your epoprostenol to atomize your milrinone, or do you run both at the same time?
inhaled,
Yes.
if they're already on inhaled.
Yeah.
You can run both at the same time.
They have different mechanisms of action. They can be additive to each other.
So, but they'll run in the circuit together without causing clotting issues or mixing of agents. You just have to remember to remove the HME filter because it will gum up in there, and that's the only issue that you'll run into, is that it'll cause that to fail, and so it'll get caught in the filter. All righty. If there are no more questions, thank you all.